Hello everyone, we are going to talk about Guillain-Barre syndrome. We'll first discuss the etiology of GBS, then we'll study the pathophysiology and types of GBS, then we'll look into the clinical features, then we'll go into the investigations and the treatment. So starting with the etiology, a GBS patient always complains of some antecedent infection, like you can complain of some GI infection or respiratory tract infection. In GI infection, Campylobacter jejuni is the most common. In respiratory, it can be COVID. Some other infections like HIV, CMV, Epstein-Barr virus, even vaccination have been proven to a cause of GBS. Now let's get into the pathophysiology. In it, suppose a patient got infected with Campylobacter jejuni, the body makes antibodies against it. So these antibody cross react with the Schwann cells, causing demyelination of the neurons and resulting in the following features. So this is the basic pathophysiology. Coming to the types, how can GBS present? It is of various types. The most common is the acute inflammatory demyelinating polyneuropathy. In these antibodies attacks the Schwann cells, but the good news is these Schwann cells have the capability to reform and recover. Some other types are axonal motor neuropathy, and a rare form is acute motor sensory axonal neuropathy. And the antibody find in the AIDP is anti-GM1 antibody. And one of the close differential of GBS is Miller-Fisher syndrome. In it, just remember for the time being, the antibodies and anti-GQ1. Now coming to the clinical features. Clinical features will be the patient will present as ascending symmetrical flaccid paralysis. He will complain of weakness in both the limbs. He will have rubbery feet, unable to walk, even rise from the bed in the later stage due to the truncal muscle weakness. These are the motor manifestations. He will also have radicular pain. In sensory manifestation, he will have loss of sense of vibration, proprioception, as the thickened myelinated fibers in the dorsal column are responsible for it, and these are demyelinated by the antibodies, so these features occur. Also, you will see cranial involvement in the later stage. The most commonly is the facial nerve involvement. Later, it can involve the ninth, 10th, even ophthalmoplegia can also be found. And finally, even autonomic dysfunction is also seen in the patient, resulting in fluctuations in the blood pressure, heart rate, erectile dysfunction, emotional lability. Now coming to some close differentials. Close differentials can be transverse myelitis in the other myelopathies, but the thing to differentiate here is in these spinal cord lesions, there will be a specific nerve point, and even bowel and bladder involvement is a key feature to differentiate. In GBS, bladder and bowel is usually spared. It gets involved in the later stage, whereas in these spinal cord disorders, at the onset itself, bladder and bowel involvement is seen. Now coming to the treatment part. Before treatment, you must know that GBS is a monophasic disease, like it achieves its peak deterioration within the 28 days, which can be a differentiating feature from CIDP. In investigations, you will advised for a nerve conduction velocity and CSF examination. In CSF examination, you will find cytoalbugenic dysfunction, where the albumin levels are raised, but the cell counts are normal. And nerve conduction velocity will find F wave latency, decreased velocity, conduction velocity. And coming finally to the treatment we give either IVIG immunoglobulins or we go for plasmapheresis. There is no such role of steroids. So this was all about GBS. Apart from this, you can also carry out the conservative management and supportive care, like giving the DVT prophylaxis, some passive movements, managing the nutrition and all. In the final stage, when the force vital capacity is less than 15 ml per kg or there is a neck muscle weakness, there is the indication for intubation as well. So this concludes the topic. Thank you for watching.